Well, hello and welcome to today's webinar, Operationalizing NLP to Support Value-Based Care. I'm Carol Flagg of Answers Media Network. Thanks for joining us today. Healthcare providers are facing an urgent need to streamline operations while improving quality of care and patient satisfaction. With a wealth of technology, hype around AI, natural language processing, or NLP, and big data, how are providers to know what investments to make and how to bring these technologies into production use? On this webinar, we address this question by exploring the practical uses of NLP in healthcare and give real-life examples of how Atrius Health has implemented processes to improve clinical documentation, identify at-risk patients, and streamline their ACO reporting. Our presenters for this event are Dr. Craig Monson and Dr. Joe Kimura. Craig Monson is a board-certified internist and clinical informaticist. He is the Medical Director of Analytics and Reporting at Atrius Health and a Fellow at the University of Washington's Department of Biomedical Informatics and Medical Education. His current work for Atrius includes operationalizing advanced analytics to enable the transformation to value-based care and building new products that help clinicians make sense of the deluge of patient data they face today. Joe Kimura is the Chief Medical Officer of Atrius Health and an internist at Harvard Vanguard Medical Associates, a medical practice of Atrius Health. His background includes leading ambulatory care delivery system improvements using his expertise in clinical informatics and healthcare data analytics. Since 2014, he has served as co-chair of the ONC HIT Federal Advisory Workgroup on Advanced Health Models and Meaningful Use. He has also been nationally recognized as a top 25 clinical informaticist by Modern Healthcare and one of the 30 leading CMIO experts by Health Data Management. Before we begin, please note you can post a question to our panelists by using the Q&A tool box found on the right side of the webinar dashboard. Also, a copy of this recording and slide deck will be emailed to you 24 hours after the event. And now I'll turn this presentation over to Dr. Monson and Dr. Kimura.
Thank you so much. This is Joe Kimura talking, and it's a pleasure to be here today to talk a little bit about some exciting work that we're doing here at Atrius Health that we've been on this journey for quite a while, I would say, since about 2015, really beginning to answer the questions around how natural language processing could be helpful in what we're trying to do to care for our patients and our populations here at Atrius Health. Through this presentation, Craig, Simon, and I will try to hit these 5 bullets. First, give you a little bit of context around my practice, and why something like NLP could be important for us. Thinking about that, and then talking about how those selected use cases in NLP should hopefully provide some illustrations and some pragmatic examples for how this can be applied in medical groups, delivery systems, trying to figure out how to advance quality clinical care and medical expense management activities for a practice. So with that, let's jump in. Next slide, please. So a bit around Atrius Health. So we are a large integrated multi-specialty practice that brought together 4 practices in 2015, including a VNA service together. We now have about 900 physicians, 50 specialties or so, caring for 750,000 patients in the eastern Massachusetts area. And in many senses, our practice evolved, a big chunk of our practice at Harvard Vanguard Medical Associates evolved from the old Harvard Community Health Plan model, which was an integrated delivery system started in the 1960s. Some of our other groups that have joined from Dedham Medical Associates and P&G actually predated Harvard Vanguard along those sides. But in many senses, we share a common ethos around clinical care, which is really very much aligned with the construct of value-based care. We are unique in our eastern Massachusetts market in the sense that about 70 to 75% of our annual revenues come from full risk contracts. In our practice overall, much of our infrastructure, much of our capabilities has been geared around the fact that we have been accountable for quality of care, patient experience, medical management, and the total financial side of things when we're really responsible for the total cost of care for the patients that choose to come to Atrius Health for their care. It is interesting because, again, in this Eastern Massachusetts market, we are a physician group with a VNA, so we actually are independent from any hospitals in our marketplace. We utilize many of our academic colleagues in our particular market, but again, with respect to full risk, we actually bear a financial risk for those hospitalizations, those ED visits, those skilled nursing facility costs, and therefore our practice has built an infrastructure and a capability to make sure that we are managing that population as aggressively as we can for the, now over 20 plus years at this point in time. I think informatics, NLP technology, advanced analytics capabilities are part of what I would call the core competence required for a value-based care organization to really be successful going forward. Namely because as we're attributed or we take responsibility for those populations, it's important for us to treat the patients even if they are not coming in to see us in a face-to-face encounter, even if most of their utilization is outside of our four walls. We've accepted responsibility and feel that it is our role to be able to engage those patients proactively and to be sure that we're pushing as much as we can into the most safe, cost-effective place possible. In many senses, our clinical care is oriented around prevention being the ultimate form of treatment, and therefore, as much as we can go upstream in the clinical care pathway, that could be very beneficial for us, and we believe is the best kind of clinical care to provide for our patients and our populations. Because of that, we've invested heavily in informatics. We are a HIMSS Stage 7 practice. We've been now almost 2 decades on Epicare and have worked with that EHR system extensively. For over 15 years now, we've actually had, because of our claims and our risk acceptance from our local health plan payers, integrated an all-payer claims database with our Epic data in order to create a sort of a uniform data infrastructure with our own MPI capabilities to be able to drive a lot of our population health activities, our medical management, our quality activities across the practice. So hopefully that gives a little bit of context for the practice and again, why we as a practice have invested the time, the effort, and the intellectual capital to really try to explore NLP earlier on, particularly as value-based care has advanced in the markets. Next slide. Quick sort of, this is kind of tooting our own horn a little bit, but a couple of months ago we did get the scores for quality and savings for ACOs. We were one of the original 32 pioneer ACOs. We are now our next gen ACO going forward. But in the final year of performance in 2016, we are proud to have come out first in terms of quality of care, and we were fourth in terms of returning savings back to Medicare along these lines. And again, I think what we're citing is the fact that we have been accountable for quality of care, patient experience, and the value of care across our spectrum, not just in the Medicare space, Medicare Advantage and Pioneer. In the Medicaid space, we are one of the practice heading into an ACO type structure that Massachusetts is launching in March, as well as within our commercial space where we have the bulk of our risk patients coming from. And so this is not a small part of our practice, and this is fundamentally well aligned with how the clinicians and the administrators and the entire practice are thinking is the best way to deliver care for patients in the population. Next slide. So in many senses, we're trying to say, what is NLP and why is it so important? And we'll start here with what is NLP. And I know that Simon and Craig will dive into the technical capabilities here more, but from my perspective, if I could simplify it, I would say it's technology that allows us to extract concepts from free text, what we call unstructured data, from clinical reports or clinician progress notes within the electronic health record or potentially other documents where it's not a field or a number or something that can get extracted in itself. It's sort of what we call natural language in terms of text. It is more than keyword search because I think there's a lot of technologies out there that will just search for the word extraction, concepts, text, and give you sort of the prevalence of those words within a document along those lines. And it's not just what we call speech to text, where you're taking dictation from a clinician and translating that into text for, again, we think about scribe software and other things along those areas. So the idea is that you're taking a body of free text and you're starting to identify concepts from within that text. And the concepts could be something very simple, such as COPD, chronic obstructive pulmonary disease. Does the patient have COPD? And again, if you're just looking for words, you would just be looking for those particular words within a text. But we know from a clinical construct that having COPD is very different than just having COPD written within your chart at some point. A more complex construct and concept is something called sentiment analysis. For example, using something like a customer service reply coming back to Atrius Health from one of our vendor partners and doing an analysis that suggests that this was a negative sentiment based on the word choices and the diction that was actually included within that customer service reply. Again, not just a keyword search and highlight, but again, stringing together the analysis to sort of understand the underlying concept represented within the words. So next slide. So why is this important? Perfect. So for us, more than that, maybe 5 to 7 years ago, we had been doing a lot of population health management activities in the 2000s, really creating a lot of registries, a lot of decision support tools. Our clinicians and our central quality teams were really trying to squeeze what they could out of claims data, the diagnosis, the encounter data, as well as EHR information, the medication list, the problem list, the encounter diagnosis, etc. But all of us knew that, again, a lot of the really critical clinical information is not always represented within the what we would call structured data within either of those data sources. And so as NLP became a little bit more accessible, I would say, to groups like us, where we're not a software company and we don't claim to have that kind of expertise, we did begin to ask, was this technology something that we could leverage in order to be able to get more value out of the text and the hard work that our clinicians were doing documenting what was happening for patients? And we had been working initially with Simon's team in 2015, I think is when we first started talking, but very similarly afterwards. This slide will show that we started also collaborating with Dr. John Weiner's team down in Johns Hopkins, the Center for Population Health Information Technologies, and began to say, can we apply these technologies to help us identify some of the constructs that are not well represented within structured data? And I think this paired with another study that we did with some colleagues at the Brigham looking for risk factors for medication not adherence that, again, lead to factors that are clinical constructs that many clinicians would know, but it's not really coded information in the chart. And so the question was open for the practice, can we use this technology to capture these things? This is a chart that actually Dr. Weiner's and the Hopkins team has generated, and I think this is in submitted to press to be published soon along these lines, but looking at frailty in the elderly population. We were working with Dr. Leff's team down at Hopkins as well, too, to say there's an academic construct that is really important around whether or not a patient potentially could be considered frail and therefore eligible for some sort of proactive management from the practice perspective. But we weren't seeing these variables showing up in a lot of the structured data that we saw. And I think this visual sort of really highlighted that and made it really crystal clear for us that if we were to really advance healthcare in the future, started addressing things like social determinants and other factors like social isolation, et cetera, that we needed a way to be able to unlock the information that was in the EHR. And again, as you look across here, the green is, again, where these constructs, stool incontinence, malnutrition, weight loss, fall risk, social supports, and walking difficulty are represented within the EHR free text. The blue circle is within the EHR structured, and then the red circle is within the financial claims information we're getting from our health plans partners. And so when you look across and you can see particularly striking is social supports, is really difficult to see that, and therefore under-captured and under sort of appreciated within our practice population if we are only dependent upon traditional EHR or claims data. So this was actually a big aha and a very striking visual representation for myself and the practice that, again, committed ourselves to say this is technology that we're going to need to figure out how to better leverage in order to be able to get a lot more value out of the data that we're creating. So with that, I'll turn it over to Dr. Monson.
Thanks, Joe. Thanks for that context. And the one more, if you don't mind going to the next slide, Carol, the one more piece of context I will add before diving into the use cases is this is probably information that is known to you, just the amount of time and resource that goes into capturing concepts, in this case purely for reporting purposes, but as Joe alluded to, our interest in extracting concepts extends well beyond just reporting for the purposes of compliance with quality metrics and reporting on our quality metrics. It's to fundamentally identify and close the care gaps that our patients may experience. So there's a big number to provide some motivation for our quality metric reporting use case. But if you don't mind going to the next slide, I'd like to structure kind of my portion of this in 3 major use cases. As Joe alluded to and nicely summarized some of the context for this, the NLP represents a tool for us, and we have certainly been on a journey for some time to figure out how do we best match that to our use cases or to use cases that we can create a sustainable impact for the practice and ultimately improve patient care. So I've broken this down into 3 major use cases that we'll kind of dig down into each one of them. But as I was just alluding to, one of them is to facilitate our quality metric reporting, basically to extract the concepts that are necessary in order to ascertain those. And I'll use the example of ejection fraction in a moment. A second use case I'll describe is related to our clinical documentation accuracy. So this has implications for really quality metrics as well as a safety net I'll mention in a moment, as well as resourcing, particularly in the value-based care world. Clinical concepts that are being addressed but not coded represent gaps in or information gaps that have bearings on how we are resourced as providers to care for our population. So I'll talk a little bit more about that, and I'll use the example of our COPD and CHF diagnosis accuracy effort. And then finally on safety net, this is some exciting work that we are doing to capture disease states or even before they're known to be disease states, things that patients are at risk for evolution into some scary conditions like lung cancer, and the example I'll share are our pulmonary nodules work. So let's jump into it. The next slide is some of the background on our quality metric reporting. So as Joe alluded to, we have a number of areas of focus, but they are summarized by the concept of value. We think about that in large part in terms of the triple aim. We kind of break out safety and quality together, and then patient experience and cost are on the right there, represent an equation for what value means. The way we operationalize that is by considering and harmonizing what it means to provide quality care for us as a practice and how we prioritize that each year. That's summarized by the saturation grid below the equation, which has on the rows, our metric performance, and then along the columns, our sites, regions, and service lines who are held accountable to ensuring that we are meeting our stated quality aims. So one of those rows is our organization's focus on high-risk heart failure. So that includes actually a composite metric of a set of patients who have heart failure who evidence suggests they achieve better outcomes if they are on beta blocker. So beta blocker is one of the metrics. Then in addition, if they're on ACE inhibitor or ARB. The rub is that this does not apply to everyone for whom you would diagnose heart failure. It's actually a subset of them who are have low pump function, or equivalently, the kind of clinical phrase of that is their ejection fraction. And the challenge of that, in turn, is that that information is frequently not in the EHR and as a structured text that you can easily pull. Instead, it exists only in clinical notes or echo reports, as illustrated on the bottom here. This is an excerpt of a longer echo report that, if you're keen, you can notice on the second line that ejection fraction is greater than 55%. So this was a use case we felt was ripe for applying natural language processing. So the next slide is an illustration of where does natural language processing fit into our quality metric reporting workflow. I'm going to go into more detail on this on the end, but I did want to illustrate that, as you can imagine, the initial kind of phase of this is really to determine where the clinical notes and echo reports live. So those have to be extracted. But it's really the second box in the process where natural language processing fits in, is extracting those concepts, in this case, ejection fraction. And I'll show you a little bit more about what that looks like, what the output of that. We found that this works best as kind of augmented intelligence, whereby we are not relying exclusively on the natural language processing queries or algorithms, but rather pass it on for clinical review and ultimately to be entered, actually, into the electronic health record as structured text. That, in turn, allows us to do some metric summary and reporting, which ultimately gets us to the end, and we're really, in some respects, where the hard work really begins in closing those care gaps and ensuring that we are meeting our stated quality aims. Next slide, please. So I originally had a slide of a query, but it wasn't reproducing well. So suffice it to say for now that the general process of writing a query using the I2E tool involves dragging and drop various modules of the natural language processing pipeline and doing some configuration on each of those. So those might include things like identifying the end of sentences or negating certain concepts. This is what the output looks like. We have probably most along the rows different patients, and most interesting would be the second or the last two columns. As you can see, we pulled out what in this case, I think they're all for the most part, echo reports, but in some cases, clinical notes with the finding, so that can be entered in as structured text. And then it also provides the context of where that appeared in the note. I think, it's interesting to have these both side by side, and the concept of augmented intelligence is helpful to have the context for where that occurred. As you can see from that patient number 2, this is a scenario where, well, the ejection fraction or that low pump function was determined to be in 2005, so that's a situation where clinical judgment kind of steps in to determine, well, is this really relevant, and do we want to dig a little bit deeper to determine if this actually, serves in the denominator. Next slide. So I wanted to provide some results with respect to our work identifying patients with low ejection fractions. As I alluded to, it's that low pump function or low ejection fraction group of patients to which these quality metrics apply, and to which evidence shows that these sets of interventions actually help. So this is basically an agreement matrix that looks at natural language processing that came out of an I2E query, and whether or not the patient was identified, yes or no, as having an ejection fraction less than 40%. And along the columns is a chart review process. And as you can see, happily looking down the diagonals and then calculating that proportion there's almost 90% agreement for the natural language processing algorithm versus a pure chart review process using kind of clinical experts. Next slide, please. So what does this mean for us? I'd love to say that this was purely on the basis of natural language processing, but as I alluded to, that it is one piece of the puzzle for a much larger workflow with respect to closing care gaps. I did want to share that we have some, 2017 was a successful year for us as far as our performance on this composite metric of heart failure care gap closure, and to that I'm alluding to making sure those patients are on beta blockers and ACE inhibitors in that bundle of care. And given so this is a 3% meaningful increase in that composite metric performance, which, considering that our performance is generally in the 90th percentile to begin with, is actually something that we're really happy with. Next slide, please. So I'm going to switch gears and talk about the second use case, which requires a little bit of context on problem lists. So forgive me for those of you who are intimately familiar with problem lists. For those who are not, they are generally speaking a list of chronic conditions that applies to an individual patient, typically coded as ICD-10. And it serves a number of roles. For one, as a clinician, it helps me when I'm seeing a patient to prioritize that patient encounter and match it against their agenda when they come in for a visit. It also, given our focus on population level outreach and efforts, allows us to perform kind of centrally managed disease outreach and make sure those patients are on appropriate registries for outreach efforts. And then finally, it is the problem lists are frequently the first step to identifying what are the conditions that are going to be addressed at a given encounter, which in turn get submitted for claims and risk adjustment, which I'll explain more in a moment. Before I get into that, though, and where that fits in, where the problem list fits into that process, I just am going to, we've looked at a number of different disease categories. I'm going to be focusing on COPD and CHF for the purposes of this conversation. Next slide, please. Okay, Carol, I think you'll have to bear with me. I think this is the one with like 5. Oh, okay, no, we're not there yet. I wanted to illustrate another example of an output here. This is looking at COPD. As you can see, there are multiple findings or concepts that might be applicable to that, such as chronic bronchitis and emphysema, both types of COPD, and further, this illustrates how having the context allows for additional kind of inquiry into, is this truly a patient that has this diagnosis, or was it just something that happened to be considered? Okay, next slide, please. All right, so this has a few kind of transition points to it, but I'm starting simple, which is you have the problem lists pre-existing that are based on a patient's history of interactions with the healthcare system captured in our electronic health record. And then in the yellow box, we have what happens during an encounter, grossly oversimplified, but generally speaking, it includes on the bottom the encounter notes that's either dictated or typed with keyboard and mouse by providers. And then relevant to the kind of risk adjustment process are these encounter diagnoses. The way the problem list fits in is frequently it's from the problem list that these encounter diagnoses are populated, so that's not exclusively true. It's a appropriate first order approximation. So next part of the animation is what actually happens to all this stuff. Well, with respect to the diagnoses, those get passed on through billing for review and ensuring our documentation and diagnoses are appropriate, but then submitted as claims to our payers. The payers basically only, for the most part, only have the claims data to work with. And in a kind of managed care or value-based care or accountable care, really, arrangement, those diagnoses become the basis for risk adjustment. The reason risk adjustment is relevant is because the objective is to ensure that populations, that like populations are compared to other like populations, and that populations that are sicker are resourced in order to best manage their care. So the kind of actuarial expected medical expense is used through these risk adjustment models in order to ensure, in order to determine the budgeting for these accountable care arrangements. I'll share a little bit more about that. But where does natural language processing fit into this? In order to get there, I want to explain that, part of this process is ensuring that the problem list is an accurate representation of the chronic conditions that a patient has. And historically, the way we've done that is we've looked back and said, well, among these encountered diagnoses, are those applicable for to be considered chronic conditions? Because frequently they exist as kind of rule outs or trying to determine, or they may only be applicable to one visit. So we have this process whereby the problem lists will be cleaned up, if you will. The way natural language processing fits in here is because, as you'll notice, that really only speaks to the coded encounter diagnosis. So, sorry, there's another animation and then one more after that, but thank you. So for the encounter notes, that is where natural language processing's sweet spot is. And I'd say works much the same way, only now we have the capability to pull out that kind of rich set of data to identify, well, wait a second, this patient had been managed for COPD, just it was never identified or not recently identified as a diagnosis. So we have this process of, again, thinking about the augmented intelligence clinical review before considering adding it to the problem list. An area of opportunity, and if you click once more, thank you, is considering the kind of feed-forward process. The context for that is I did not go into medicine, nor do I think any of my peers went to medicine to be experts in the coding of visits. So something we're excited about, though still very early in our journey, is the kind of short-circuiting to some extent and using the note, in other words, the clinician's medical decision-making itself to identify and feed forward the kind of accurate set of chronic conditions that a patient has. So I spent a lot of time on that. You'll want to know what the outcome of that is, which I think is the next slide. So I kind of broke this up into two things. The first of all is, the goal of this primarily is to close our information gaps, which in turn allows us to close care gaps. So if we don't know truly what a patient has or what's going on with the patient, then we can't effectively manage their care or manage them as populations. So that's why I'm focusing on this first bullet. We identified in the last year about 100 cases of patients with either heart failure or COPD across all of our payers. The reason that's relevant for a couple of reasons. One is, if you were just to do this, purely looking at, let's say, the 20 or 30,000 patients in our Medicare Advantage, we might come up with we might have to review 1,000 patients in order to find one instance where that's truly applicable. By applying natural language processing, we kind of identified more readily where there are information gaps and enrich that number from 1 in 1,000 to 1 in 6. That in turn allows us to do all the great things of disease management and in having accurate kind of assessment of where we are as far as our quality metrics. And then the other piece it does is that second bullet, and I have to put like 100 disclaimers on this, which is to say that risk adjustment is a somewhat arcane science and an evolving one, and it's different by each payer. So it's not. I think this is probably a number you're very interested in. I can't say that this is well, I put the disclaimers on it. So. But what I wanted to provide you with is that there's some range, and I put in the ballpark of 50 to 100,000 in risk-adjusted revenue that we see per effective query. That's looking at across all payers, but it's probably most straightforward to determine for Medicare Advantage, where there's kind of a publicly available risk adjustment algorithm. And if you are in the value-based care world, you know that you should be looking at this from a per member per month basis, and that's the kind of 20 cents to 40 cents that we see. I included my kind of justification for how to get there. the basic outline of it is that it amounts to the fact that on average, well, there are these risk adjustment factors for Medicare Advantage that essentially you can think of as points of risk that determine in it, like, what is the average cost of managing someone with heart failure or COPD. Both of those happen to have a value of about 0.35. And then the other piece you need to know is that for each 1 point in risk adjustment factor, or RAF, that corresponds to roughly 10,000 per year. And so from that, you can work out that a heart failure or COPD patient on average costs about $3,500 per year more than someone who doesn't, and then that is kind of resolved in a budget reconciliation process. So I thank you for bearing with me through that part. So I'll move on to the next use case. So this is our safety network, which is an effort to make sure that our patients who have early findings of possible concerning diseases are caught early in the process, and where intervention is most effective. So where does that come up? Frequently in radiology, pathology, or procedure reports, and it's not uncommon to have ambiguous findings, or what are sometimes called incidentalomas. It fortunately is rare that they are truly cancer, for example, but it is something that merits follow-up. And so I'm going to be focusing on our follow-up with respect to pulmonary nodules, but this applies to some of the others as well. Next slide, please. So this is not going to look too different to the slide that I shared around quality metrics, but I did want to emphasize how this works, how this kind of safety net concept works. It starts by having the documents, as we saw earlier. What's really neat here, and I dedicate a slide to it, is that one of the challenges is that we're working off of frequently scanned reports, which come in as PDF. So there's an additional technology to support that, which I'll illustrate. But then the natural language processing kicks in, which allows us to go through our population health efforts. Basically, we have a list of patients with pulmonary nodules that represent a work queue. Ideally, those pulmonary nodules are old and have, shrunk or stayed stable. So there's kind of no, in some cases, there will be no need for additional follow-up. Frequently, or sometimes there will be, in which case that's where we kind of trigger the population health outreach and establish a follow-up and treatment plan. That is kind of generally what the safety net looks like. Yeah, next slide, please. So I alluded to this step that is a little bit different from the others, introduced by the fact that we have these PDF reports to scan. And I'll be brief here. I wanted to illustrate, so this is a technology, optical character recognition, that I2E has a process to make this more robust. But I would say that in general, when you have a PDF, you kind of need to use this computer vision technology called optical character recognition, whereby you take the kind of crummy looking version on the top and turn that into text on the bottom. You'll notice that there are transcribing errors that are a result of, in some cases, some of these scans are not of the best quality. But actually, we found that it's the combination of the optical character recognition plugged into the I2E tool has been fairly robust to these errors so far. Next slide, please. So I've been providing a number of kind of general workflow diagrams. This is to dig in a little bit to some of the architecture, although I kept it at a high level for the most part. With respect to our safety network, we have our notes that get regularly submitted actually on a nightly basis into our data warehouse. That works great to get text into or to examine text from our own electronic health record. But in addition, as Joe was alluding to in the very beginning, we manage our patients' care even when they're going outside of our four walls, so to speak. So we have a number of partner health systems and health information exchange processes in order to get scans that we might not have, that we don't have in our own system, which, if you go to the next step, ultimately is what we have to do in order to provide the safety net service. So forgive me for including a couple of acronyms here. The process abstracted away to 30,000-foot view involves the health information exchange step, and then the optical character recognition I was mentioning earlier in order to get these pooled text files. That in turn, if you go to the next part of the slide, is where we can submit into the natural language processing pipeline, which I2E represents our tool for. So I alluded to in the very beginning what that means precisely. I don't intend to go into details around the different components of the natural language processing pipeline itself, but suffice it to say that piece is well accommodated by I2E, and as you can tell, fits into a much larger process around how do we get the data from one place to another, i.e. data operations management. Once we've done that, this kind of grid represents what gets submitted for clinical review and management. And then the last piece there, and what remains an area of opportunity, is how do we get this to be a kind of the feedback mechanism by which that information doesn't just go to the clinician, but gets entered seamlessly into the electronic health record, and then that in turn gets fed back through the actions that people take, the notes that they create, and then the natural language processing step continues. So some work to do there, which I kind of summarize on the next slide. I don't intend to give you the impression that natural language processing and our use of the I2E tool represents a panacea. I have kind of summarized some of the points of the last slide here, which is to say that we've been really happy with the I2E tool solving the natural language processing part of the pipeline. We could talk a little bit about query construction. That is a piece that remains, that is a part of using the tool. I think the part that we are grateful for working with Linguamatics on is their willingness to go on this journey with us as we figure out the data operations piece and make it truly a smooth, seamless part of our of how we communicate data about our patients to our clinicians and population health managers. So I think my last slide is really to illustrate where we're going with this. I illustrated one of our safety nets and alluded to the opportunity for several others. In addition, I think those have a very medical focus, but we are participating in Massachusetts Medicaid ACO, and that represents for us an opportunity to consider anew how are we closing information gaps and care gaps with respect to some of the largest contributors to patients' wellness, their social determinants, and behavioral health. So we've adopted an approach of course, some component of this is going to be capturing concepts through structured health risk assessment, and in addition, identifying populations for whom we're not routinely capturing in a structured way through our natural language processing is an effort we're undergoing now with a particular emphasis on homelessness, but in addition, some of these other concepts illustrated on the right. And then, of course, that is work that is ongoing concurrently as we examine our operational improvements about how do we close those care gaps once that information is reliably available to us. So I think we're on my last slide, which is really to thank the multiple contributors to this work. Thank you, yeah, the acknowledgements. On the Atrius side, I start out by thanking our analysts, Vera, Yoni, Sanjukta, Leilani, and Sue, who have been kind of the tip of the spear in our understanding the I2E tool and natural language processing. And then our kind of business owners, I might call, are those who are helping us identify and match the tool to the use case, including Judy, Sean, Tom, and Peggy. And then I'm going to turn it over to Simon in a moment. I'd like to thank him somewhat awkwardly before he talks, but for being, as I alluded to earlier, a welcoming partner in exploring matching the tools to the use case. And then a lot of his, who have really been our support on the technical side, including Elizabeth, Kathy, Marco, and Aaron. So with that, I'm going to turn it over to Simon.
Thanks very much, Craig. So Simon Buehler here. I lead the healthcare team at Linguamatics. I'm certainly very happy to be working with Atrius and with Craig and Joe on this journey into discovering how to make the best use of unstructured data. I think from what you've seen today, there's very much this concept of needing a comprehensive view of the patient, of the person, to help us better organize their care and make sure that they maintain their health. And we do see a major distribution of information, as many of you know, between the structured and unstructured data. But really our main focus is in supporting and bringing that unstructured data into a structured world to support the types of analysis that Craig was talking about, the quality measures, the clinical documentation, and the safety nets. So I'm just going to talk about that in a little bit more detail. Next slide, Carol. So when we look at the functionality that's required in working with unstructured data in a clinical environment, there are just three components I wanted to highlight, and then I'll give some examples of what they mean. Being able to explore large-scale data sets is really important from an NLP perspective. We need to understand the variability in language that's used to make sure that we have captured all the different ways ejection fraction, A1C, BMI, COPD values for FEV1 have been represented, to look at how social determinants, for example, are represented within the text. So that's a key component. The ability to democratize NLP, we provide a non-coding, it's a drag and drop environment. You don't need to be an NLP expert to make use of the tool, and it makes for a very interactive environment. And what it means is that analysts and data scientists who typically work with structured data are able to learn how to use NLP and incorporate that into their analysis. And then Craig also alluded to the desire to automate these processes. That's something certainly we're committed to working with our customers on. Integration with Epic is something that we discuss a lot, and certainly our goal is to allow that to be more of an automated process to get updates to records, process them, and then return the data to the EHR without too much human intervention. Next slide. So just to illustrate, we've touched on social determinants of health as being an important factor as we look at the value of unstructured data. And certainly Joe's slides from JHU illustrated very well that social determinants are not well covered by structured information. And when we consider attributes such as living location, social support network, ambulatory status, these all have major implications clinically as to potential risks for each individual. If a person is being discharged from the hospital and they're going home with their husband, they don't have any ambulatory issues, you would not be too concerned. If an older person lived alone and was using a walking cane, then that's something we'd want to take into account. So we've done various studies. This is a large study analyzing discharge summaries. And here we've got to work with the clinical bias, what information actually is captured but within the discharge summary. Generally, there's more information if there's more concern, so that helps guide us towards the right patients who need more support. In this instance, we're frequently taking the output of our NLP processes and loading those into machine learning and statistical models to help us extract this data. And in this case, we took a data discovery approach. We looked at all the different ways family members, ambulatory status, comments, living locations were represented, and then built new ontologies to help us structure that data. Next slide. Another area of interest, this is another predictive model that we looked at around opioid abuse. This is looking at well-established clinical questionnaires which are looking at particular factors, and these are often given when the clinician is already concerned about opioid abuse. We've simply taken those questionnaires and applied them to clinical records. So in this case, identification of family history of drug abuse or alcohol abuse, psychological problems, sexual abuse, drug abuse previously by the individual, whether the individual has a history of alcohol abuse. All of those concepts can be extracted from the unstructured notes and potentially again flagging up high-risk individuals. So this is a nice extension of the safety net concept that we were talking about in the last example. Next slide. And then just I wanted to highlight what another group has done on the pulmonary nodule area. Certainly with the larger health systems who maybe aren't as value-centric, the litigation risk for pulmonary nodules is significant for the larger health systems. A couple of groups that we work with are actively monitoring radiology reports overnight. This is a system that has been run over about 14 months, flagged up 1,200 cases, of which 64 were biopsied and 37 were malignant diagnoses. So obviously that gave us the ability for an earlier treatment and improved outcomes. And really that's what the safety net is all about. It's improving the outcomes and reducing risk for the health system, so that this is a really high value application area that a lot of groups are looking at. Next slide. And then that's, I just wanted to again thank Atrius for all the time and effort and work they've done with us. It's been a really, as I said, exciting journey, and we look forward to continuing that with Joe and with Craig, and I just wanted to specifically thank them for taking the time to share their experiences with us today.
Great. This is Carol jumping back on again. Thank you so much to our panelists for all of this information. We do have about 6 minutes till we have to end our event today, so I'd like to get a couple questions in front of you all to answer if that sounds good. And I'm just going to take some from the attendees. The first question is, have you found providers are less likely to use discrete fields if you enable them to use free text and NLP?
It's a great question. I'll take that one unless you have a perspective on it that you'd like to share as well, Joe. I think the reality is that, part of that, through that $15.4 billion in reporting, and that's just for the kind of pieces that are necessary for quality metrics, not to mention like all the other things that we throw on our providers with respect to documentation. I guess I'm not really sure how to answer that question easily in terms of, well, if you provide a NLP process for, what was otherwise entered as, or what might otherwise be entered as structured text, like, I feel like that might get at the wrong, I feel like I guess it's not the approach we take, even in answering that question. I would say that our focus is, well, how can we serve the needs of our our patients and promote our population health management efforts in a way that is compatible with the workflows that our providers have adopted. Which is not to say that, you know, you can't ask a provider to enter a piece of information as structured, but at a certain point it's just not viable to enter everything. Like there's truly information lost out of the kind of narrative text of a clinical note or report. So I think there is certainly a trade-off and balance to strike as to how we do that, and how much we ask is structured and how much we leave to narrative. And it's our expectation that and our findings, frankly, that you have to do both, because even if you did adopt the strategy, I mean, it might be worth a shot of purely structured text. You're not going to, that's not going to change overnight.
Right.
Can
Right.
I add one bit there?
Sure.
So I guess I would add in terms of, so I do think there's, particularly in value-based care, there's an increasing demand to capture new constructs and new concepts. And we know that there's an epidemic of clinician burnout on the front end of this in terms of the amount of work and burden that's there. So I think it's an interesting place where we can ask if this technological ability, NLP to me in my own mind is like regression models. You can apply it to a lot of different things. Is there pain points that we can use that helps us not only get better data for patient care and population health, can we also use it to potentially decrease the burden on the front line? I think it's a powerful construct that could be applied at many different spots.
Okay. And who would be the typical user of NLP, and what skill sets would they need?
I think as articulated, I think Simon mentioned it with respect to the use of the I2E tool. In our experiences, our data analysts are best equipped to work with the tool, in part because they're quite familiar with the data and some of the extraction needed. I'd say that in some respects the end user is ultimately a clinical one, but as far as constructing the queries, yeah, it's typically data analysts or data scientists.
Okay. How does 70% of revenue from risk contracts compare to other groups, and how has this grown over the past years?
You want me to take that, Greg?
Joe?
Yeah. So it's, I think we're unique with respect to the percentage of our revenues being so high. And again, I think most across the country, the numbers are still sort of in the low single digits to maybe 20%, maybe a little bit above that. So we are definitely an anomaly in this market, and probably unique in the country around the amount of risk we take. And it's, I don't think we as a practice haven't moved from 0 to 70%. We came from an environment that we were an integrated delivery system with one health plan in the sort of 1960s and 70s, and now moving to a multi-payer environment since 2000 going forward. And so in that sense, we've seen our numbers of pure full risk drop, but I think the rest of the country is still lower and starting to increase along those lines. I don't know where we're going to settle along those lines, but I think for our practice, the financing model of full risks is very nicely dovetailed to the clinical style of medicine that I think our clinicians really are committed to, around really pushing prevention and trying to find the best value for our patients.
Yeah. One of our attendees chatted in, this was a great webinar. Thank you for allowing me the opportunity to learn more from your team, and I couldn't agree more. I want to thank all of our panelists for the great information today, the presentation, and for your insights. Also, everybody will get a copy of recording and the slide deck post-event. You give me 24 hours to put all that together. And especially to our attendees, thank you for taking time today. Dr. Kamara, Dr. Monson, and Simon, thank you for the presentation, and hopefully we can do this again sometime.